welcome Professor Anthony McCarthy, Consultant Perinatal Psychiatrist, National Maternity Hospital in Holles Street. You're very welcome to this evening's meeting. And ordinarily I would read through the privilege and the Defamation Act. Are you familiar with that, or would you like me to go through it?
No, I have spoken at these committees before.
Yeah, I figured. I just have to check because I'm saving everybody having to listen to me say the same thing 3 or 4 times a day. So I now call on you to make your presentation. Thank you very much, Professor.
Okay, thank you, and thank you for inviting me to address the committee. I hope to be able to answer any questions which members might like to ask by bringing the benefit of my experience and expertise and my knowledge of the research in the field of pregnancy and mental health and illness. I've worked as a consultant perinatal psychiatrist at the National Maternity Hospital in Holles Street for the past 21 years, where over 500 women attend my clinic each year. Women are seen who are pregnant or are in the first 6 months post-pregnancy, which includes pregnancy loss, and where a significant mental health issue is involved. Women attending may have a previous mental health history, or a significant new crisis may develop during or after the pregnancy. Amongst those who attend will be many who have suffered a miscarriage, others may have had a stillbirth, or may have a baby diagnosed with a significant abnormality of varying levels of severity, or may have had a previous termination, or may be considering a termination. I've previously spoken as an expert witness at the 2 Oireachtas hearings, which led to the introduction of the Protection of Life During Pregnancy Act. I was also invited to speak as an expert witness to the Citizens' Assembly. I'm also an expert assessor for the confidential inquiry into maternal deaths in the UK and Ireland. This involves detailed study of the records of women who have died during pregnancy or in the first year afterwards as a result of suicide or other mental health causes. So what can I say now after all of these years of working in this area and from my understanding of relevant research and history? That while having a baby is hopefully and fortunately for many one of the most joyful, rewarding and meaningful experiences of their lives, as you all know, it is also unfortunately so often not like this. You know this from your own lives, those of your families and friends, and of course also from listening to many of the stories told here to this committee and to the Citizens' Assembly. Most of you have heard of or personally witnessed stories of depression or distress, of unwanted pregnancies, of rape, or the discovery of major fetal abnormalities, or the termination of pregnancies in the UK and here in Ireland. These are stories heard so regularly in my clinic in Holles Street. Abortion. Oh yes, in an ideal world, it would never be needed or requested. But even if we exclude medical emergencies and severe life-threatening indications, we cannot wish abortion away. It has been a part of the history of every country, including Ireland. And before it became legally available in the UK 50 years ago, and therefore available for thousands of Irish women every year since, it was illegally available here in Ireland for those who could pay. And of course there was infanticide too, which was such a widespread practice. I would urge anyone who is unaware of the nature or extent of this to read Cliona Rattigan's seminal history, What Else Could I Do? A detailed study of hundreds of cases of infanticide in Ireland between 1900 and 1950. Or the work of Dr. Elaine Farrell, who studied 4,645 infanticides in Ireland between 1850 and 1900 and published her work entitled A Most Diabolical Deed. Dr. Rattigan quoted a judge in County Clare in the 1930s who described the epidemic of infanticide cases he had to hear. And both studies emphasised that these numbers were an underestimate of the true scale of infanticide in Ireland at that time. We don't want to go back to an era of illegal backstreet abortions and infanticide. In my clinical work, of course, most of the women who I see for whom a termination of pregnancy is an issue, they're seeing me because of their or their partner's concern about their mental health. Sometimes that termination could be potentially very damaging for them. For example, a woman who has a planned and much wanted pregnancy but who develops severe depression, which is clearly clouding her judgment about everything in her life, and not just the pregnancy, keeps thinking she should terminate because she'd be a bad or evil mother. She needs expert help for her depression. A termination is almost certainly not what she wants and could be very damaging for her mental health long term. But for another, she is clear she cannot continue the pregnancy. She cannot cope, and continuing the pregnancy would destroy her life. She's in no way mentally unwell, but she may be terrified of becoming unwell. How any woman responds to a pregnancy is so personal to her. how she visualises and imagines what it is or is not growing inside of her is unique. For example, one woman with an early miscarriage will say that what she has lost was just a pregnancy for her, not a baby, that she knows it happens in 20% of all pregnancies anyway. It was just nature's way. It was just like a heavy period. For another, she may have a huge sense of loss of a baby. She may name it, grieve for it, even if the scan actually shows a so-called empty sac, or even if she has a rare molar pregnancy where there was only ever placental tissue. There was no fetus whatsoever, but her pregnancy tests were positive and she's grieving as if it was a baby. It is these sorts of inner perceptions and beliefs and imaginings that determine so much, and so much more so than any biological reality. It's part of what makes us human. For example, one woman with a baby with a fatal fetal abnormality may decide that she or they want to continue the pregnancy because she wants to hold that baby inside of her as long as possible, and she hopes the baby will die inside of her, and not shortly after, as she feels it is safe and warm for the baby to die inside of her. Another will feel she can't bear to think of the baby suffocating inside of her, or being in pain, or the distress of it dying inside of her. She loves that baby, but she'll want a termination and she'll love it afterwards. Another will say she wants the baby delivered early and hopefully alive so that they or she will have the opportunity to hold the baby for a few minutes before it dies, but may bring the pregnancy on early for that very reason. As doctors, we must be aware of the complexities involved for everyone and listen and not prejudge. I wish now to address the question of mental health outcomes after induced abortion and the research evidence in this area. This has been mentioned by members of the committee and some speakers in earlier sessions. The first key point is that no significant research has been done on this subject in Ireland, and that's important. Research from the UK or the USA or Australia may not be applicable here, or maybe only partially applicable, and it's different here. Secondly, there are so many other limitations to nearly all of the research done in this area. These limitations include serious researcher bias, inadequate control for confounding variables, or inappropriate control groups, and the failure to control in particular for previous mental health problems. Therefore, my advice, and particularly for those who aren't used to reading medical papers, is to read any such research in a critical, informed and objective way. The best overall publication in this area is by the Academy of Medical Royal Colleges in the UK. They published a systematic review of the mental health outcomes after induced abortion, in which they reviewed all of the research available evidence and critically analysed all published research which reached basic scientific standards. So it was an overview of all the studies. Their key findings were an unwanted pregnancy in itself is associated with increased risk of mental health problems. That the rates of mental health problems in unwanted pregnancies were the same after termination or after giving birth. No higher in either. That the most reliable predictor of post-abortion mental health problems was having a mental health problem before the pregnancy or abortion. And that in addition, women who were pressurised to have a termination by a partner, or women who were exposed to strongly negative attitudes towards abortion in general and to her personal experience in particular, were more likely to have long-term mental health problems. However, for any and every woman who might seek mental health advice in this situation, it will be the specifics of her individual situation and her distress and her history and her personal beliefs and wishes, and often her partners too, which must be listened to and understood. The research evidence is helpful in general, but never specific to any individual life situation. The dilemmas for women in such difficult situations will always be painful and distressing. I consider it my responsibility as a psychiatrist in Holles Street not to add to this pain and distress, and I hope the committee will be of the same view. Thank you.
Thank you very much, Professor.